Welcome back everybody, David here with Med School Boot Camp. So in this next video, we're going to talk about membranoproliferative glomerulonephritis. Overall, compared to some of the pathologies we've talked about in this chapter, this is a relatively rare condition. However, it's very important to know that this particular condition can actually present as a nephritic or a nephrotic syndrome. And recall that there are a lot of overlaps and similarities between nephritic and nephrotic syndromes, including things like proteinuria and edema. But one of the key distinguishing factors between a nephritic and nephrotic syndrome is the presence of red blood cells in the urine, which for simplicity is how we kind of differentiate our nephritic versus nephrotic syndrome. It's also important to note that in membranoproliferative glomerulonephritis, the pathophysiology includes mesangial cell growth and proliferation, which leads to splitting of the glomerular basement membrane, but there are two primary types of this condition, including type 1 and type 2. Type 1 is immunoglobulin mediated, and immunoglobulin mediated means we have immune complexes that form in type 1, such as an antigen-antibody complex, that then make their way to the kidney, specifically to the glomerulus in the kidney, and ultimately lead to complement activation, which can then damage the filtration barrier. These immune complexes can then deposit in the filtration barrier, specifically the glomerular basement membrane, which is important to know for when we look at the diagnosis portion. We can see that in type 1, which is the more common of the two, we would see granular appearing subendothelial immune complexes on immunofluorescence. And this makes sense to us, right? Because we said type 1 is immune complex mediated. It makes sense then that those immune complexes causing damage in the glomerulus are something that we'd be able to see on immunofluorescence. It's also important to note that in both of these types, we're going to see glomerular basement membrane thickening and splitting in a tram track appearance on light microscopy. This tram track appearance is a bit of a buzzword that they'd like you to know. And what's going on there is that these immune complexes we talked about previously can actually go and then bind into the glomerular basement membrane. And what do you think this is going to do to the basement membrane? Well, it's going to increase the inflammation in the area. It's going to increase the thickness of the basement membrane because remember we said we put more stuff into an area that's going to cause it to become thicker and thicker. And ultimately, we're going to see mesangial cell proliferation in the basement membrane. And this mesangial cell proliferation can lead to splitting of the glomerular basement membrane. And as you can see, a split glomerular basement membrane in theory kind of looks like tram tracks. And so that's what they mean when they say there's a tram track appearance on light microscopy. The other thing that's important to know that applies to both of these conditions is a decreased C3 level. And we've talked about this previously, right? Anytime we activate the complement system, it makes sense that if we're activating more of our complement system, more of our C3 in a particular area, that we would see less C3 in the serum. So for type 1, although it's immunoglobulin mediated, it ultimately does activate the complement system downstream. And type 2 is of course complement mediated, and thus they share this feature of decreased C3 level. So now let's dive into type 2 and talk about the differences. So in type 2, I put a high yield button by the fact that it's complement mediated due to a C3 nephritic factor. So how does this process work? Well, the C3 nephritic factor is an autoantibody that stabilizes C3 convertase. And so this IgG autoantibody stabilizes C3 convertase, which is normally a molecule that converts C3 into C3a and C3b. So by stabilizing this convertase, we are getting excessive or overactivation of this molecule. This should make sense then why we have low circulating C3 levels, because we're constantly consuming the C3 and thus creating lower levels in the serum. And then what happens is that these molecules, C3a and C3b, can then go deposit in the glomerular basement membrane, leading to our classic finding of dense deposits. So you can see in type 2, which is less common, we see that it's complement mediated and called dense deposits. Well, the dense deposits are composed of molecules that are being created by an overactivation of C3 convertase. So this is why we consider this to be a complement mediated condition, because it's directly caused by the complement system, as opposed to type 1, in which it was an immune mediated system with a downstream complement activation. Here we're just directly activating the complement system. Why? Because we have this autoantibody that is allowing continuous activation. And while technically there's a type 3 membranoproliferative glomerulonephritis, we don't understand the mechanism quite as well, and thus it's not really tested at this level. So the management for this condition, very similar to what we talked about with some previous pathologies, is that we're really trying to do symptomatic management and avoid progression to end-stage renal disease. So this might include things like immunosuppressants, because we know that these can kind of tone down the immune system and the complement system as well. And finally, for some classic associations with this condition, we already talked about the fact that this can be presented as both a nephritic or a nephrotic syndrome, depending on symptom severity. It's also important to know the etiology, and that type 1 can often be idiopathic, as in we don't know what the predisposing cause is. It can also be secondary to hepatitis B, hepatitis C, or cryoglobulinemia. And the key associations I want you to take for type 2 include the association with the C3 nephritic factor. And remember, this is a stabilizing IgG autoantibody that leads to overactivation of the complement system. It can also be secondary to hepatitis B, hepatitis C, or cryoglobulinemia as well. And so the classic presentation that they might give you for this pathology is to talk about a patient who has a history of potentially drug use that may involve the use of needles. This can clue you into these patients being at a higher risk for infection, such as a hepatitis infection. And then they could talk about how a patient has these signs and symptoms of hepatitis, or maybe they have a known history of hepatitis and they're starting to develop some very serious kidney problems. They might give you some lab findings such as decreased C3 levels. And these are all going to be clues that you're using to answer this question and clue you into the fact that, oh, this patient might have membranous proliferative glomerulonephritis, based on their risk factors, based on some of the labs I'm seeing, and the addition that they have a presentation similar to a nephritic or nephrotic syndrome. So just a quick summary for this video. We talked about the pathophysiology of the two different types. Remember that type 1 is primarily immunoglobulin mediated, and note that these immune complexes tend to bind in the subendothelial region of the glomerulus, versus type 2, which is more directly complement mediated, and it's more likely to involve the creation of dense deposits in the glomerular basement membrane itself. We also need to keep in mind that a lot of times the management for these conditions involved avoiding end-stage renal disease or progressive disease, and thus we're trying to do things such as symptom management or immunosuppression. And finally, some key associations I want you to keep in mind for these is that this can often be a nephritic or a nephrotic syndrome. Type 1 is much more common. It can be idiopathic. And that type 2 is typically going to involve this C3 nephritic factor. So if you can go through each of these pathologies in this section and kind of think about one or two things that make them unique, also while remembering that they fall under the umbrella of a nephritic syndrome, I think that's a really good way to make sure you have the information that you need for test day.